Thank you for attending our virtual event, Cleaner Healthcare, Reducing Hospitals' Greenhouse Gas Emissions. My name is Shanna Krishop, and I'm the Public Health Director at the Bipartisan Policy Center. The purpose of our discussion today is to further examine ways that the federal government can support hospitals in taking the first steps toward reducing their greenhouse gas emissions. I'll provide a few opening remarks and then turn it over to Dr. Joseph Bentecourt, President of the Commonwealth Fund, to provide his perspective. We would also like to extend our gratitude and thanks to the fund for being a dedicated partner in this project. Then we'll hear from former Majority Leader Bill Frist. As a former member of the Senate, physician, and current chair of the Nature Conservancy, this topic is near and dear to his heart. Finally, we'll have a roundtable discussion moderated by Joanne Keenan, who is, among other things, a contributing editor to Politico magazine. Joanne will help tease out some of the challenges and solutions of helping hospitals reduce their greenhouse gas emissions. I'm pleased that we'll have three outstanding panelists. We have an expert from the EPA, Mr. Clark Reed, National Program Manager for Energy Star, as well as Dr. Hardeep Singh, an invaluable stakeholder who will provide the researcher and physician perspective. And last but not least, Michael D. Roberts from Atrium Health in North Carolina. Using the triple bottom line of improved patient safety and comfort, improved community health, and the business case of savings, Mr. Roberts has assisted Atrium Health in achieving $40 million in energy cost savings since 2013. Before I turn it over to Dr. Bethencourt, I want to provide three brief takeaways from this project. First, there are dozens of early adopters, including hospitals, that have been reducing their greenhouse gas emissions for decades. While reducing energy footprint should be a goal for all of us, the overall messaging for healthcare sector at this time includes at least three overarching elements. First, the business case. Hospitals can save money on their energy costs, and that money, in turn, can be utilized to support patient care. Second, hospitals taking these steps are not alone. Hospitals across the country are taking aim at reducing their greenhouse gas emissions, and with spectacular success. And third, with the funds from the Inflation Reduction Act and other activities at the state, local, and especially federal level, the time to act is now. What can hospitals do? For starters, they can take advantage of existing funding. They can think about how to engage their staff, and they can start measuring their energy consumption. Finally, in writing our report, BPC identified several areas of confusion due to lack of education and awareness about the opportunities hospitals already have at their disposal to reduce their greenhouse gas emissions. In addition to discussing the potential of the recommendations of the report, BPC intends for the event today to serve as an educational starting point. One last thing, I would also like to acknowledge key staff at BPC, Gabriel or Gabe Loud and Kendall Strong. Unfortunately, Kendall cannot be with us today due to a health issue, but she worked tirelessly on this report. With her recent hospitalization, I'm sure she'll have even more suggestions about how to improve healthcare. And thanks to Gabe for stepping up and assisting in Kendall's absence. With that, I will turn over to Dr. Bethencourt.
Thank you so much, Shanna. I really appreciate it. It's an honor, privilege to be with you here. Thank you all so much for joining today. A very important issue, and we look forward to a very important discussion. I also want to extend my thanks to the BPC Health team for their incredible work. And certainly, as president of the Commonwealth Fund, I'd like to extend my thanks to Lavisa Gustafson, who works on our climate and health project, as well as Rachel Newsom, who really leads our policy analysis and engagement. So, there's no doubt that climate change negatively impacts health in many, many ways. As a primary care doctor, I see that every day in my practice. From acute events such as heat-related illness and death, to chronic illness from poor air quality, to the increased likelihood of illnesses from bacteria or animal vector to human transmission, as we recently saw with the pandemic, there is no doubt that this is a critical time in our globe's history and evolution. Just this summer, Maricopa County in Arizona reported nearly 500 heat-related deaths, the county's deadliest year on record. In New York and New Jersey, asthma-related emergency room visits increased by 82% on the worst day of air quality due to wildfires in Canada, and I saw that with my own eyes. Locally acquired malaria cases were detected in the U.S. for the first time in 20 years. Moreover, what we understand is that climate events can cripple health systems and disrupt the provision of care in both the short and long term. We've long known that these events disproportionately impact communities of color, people with low income, older adults, people with disabilities, and children. So we know that climate change is both a health crisis and an equity crisis. And healthcare is actually part of the problem. The U.S. health system accounts for 8.5% of the country's greenhouse gas emissions, a larger percentage than any other country in the world. Healthcare organizations have both the opportunity and I would argue the obligation to reduce emissions that come with the industry's size, its large carbon footprint, and its mission to improve health. Indeed, effective strategies for addressing climate change are essential attributes of a high-performing health system, which is why this work we're sharing today is so important. Like Shanna, I would also like to highlight a few actionable policy recommendations from the report that are applicable to hospitals in the short term. They include, first, requiring hospitals to report whether they utilize Energy Star Portfolio Manager or a similar measuring tool. As I've seen in my career during my focus on health equity, you cannot improve what you don't measure. Many hospitals nationwide already utilize this technology to measure energy performance, and Energy Star certified buildings use less energy and emit less greenhouse gas emissions than typical buildings. Second, the National Institute for Occupational Safety and Health at the CDC, in coordination with the National Institute of Environmental Health Sciences at the NIH, should research ventilation strategies in hospitals to determine ways to use the lowest energy ventilation while balancing risk reduction from infectious aerosols. Additionally, there are two best practices for hospitals looking to do this work that I'd like to highlight. First, leveraging funding opportunities in the Inflation Reduction Act, the IRA. We have a unique window for action. Signed by President Biden in August of 2022, the IRA committed nearly $370 billion to address climate change. New and expanded tax credits for energy efficiency, investments in renewable energy products are available to both for and non-for-profit hospitals. Second, reducing greenhouse gas emissions from anesthetic gases by gradually reducing, with the goal of eliminating, the use of desflurane gas and nitrous oxide, which have a warming potential hundreds of times greater than carbon dioxide. In conclusion, as our country and the world wrestles with climate change, hospitals are in a unique position to reduce their greenhouse gas emissions. We also know that they need support from our federal partners to do so most effectively, which is why this report and its recommendations are so critical. Whether we sit at the policy level or we're working directly with patients, all of us have a responsibility to ensure a more sustainable, resilient future. Today, we are incredibly honored to have a wonderful group of experts with us and to have Senator Bill Frist with us. I had the honor of meeting Senator Frist as he supported health equity work that I was involved in more than 20 years ago. No one is more uniquely qualified to speak on the intersection of policy and climate and health than Senator Frist. And with that, I'd like to introduce my colleague, Dr. and Senator William Frist.
The World Health Organization calls climate change, and I quote, the single biggest health threat facing humanity. The National Academy of Medicine says climate change represents one of the most significant threats to human health in the 21st century. There's no question. The long-term physical and mental health and well-being of people absolutely require a sustainably healthy planet and climate. I've been thinking about how environment affects health since my days as a transplant surgeon, when a patient's physical environment directly impacted how sick they were and the success of the transplant. Yet healthcare, the industry that should be at the forefront combating climate change, is in fact one of its greatest accelerators. The U.S. healthcare system is responsible for 10% of our country's total greenhouse gas emissions, and it creates nearly 7,000 tons of waste every single day. That's why I'm pleased to join the Bipartisan Policy Center and the Commonwealth Fund for the release of their report on the role the federal government can play in helping hospitals and health systems reduce their greenhouse gas emissions. The good news, many hospitals across the country have already begun to take action on their own to reduce their organization's carbon footprint. Just last month, the Joint Commission announced a new certification for hospital sustainability. And as noted in the BPC's report, more state and local governments are becoming interested in helping hospitals, as well as other buildings, figure out how they can reduce their own energy usage. Most importantly, and as the BPC outlines in their report, there are some straightforward steps the federal government can take to support and further incentivize hospitals to reduce their emissions. I'd like to thank the Bipartisan Policy Center and the Commonwealth Fund for taking on this challenging, vital issue, and I look forward to the discussion today.
Thank you, Senator Fritz. Thank you, Shanna. Thank you, Joe. I'm Joanne Kennan. I'll be moderating today. And with me, I have Clark Reed, who's the National Program Manager for Energy Star, Michael Roberts, who's the Director of Energy Services from Atrium Health, Dr. Hardeep Singh, who's the Co-Chief Health Policy Quality and Informatics at the Houston Veterans Affairs Center of Innovation and a professor at Baylor College of Medicine. I'm going to try to get everybody jumping in quickly into this conversation. I've been a health journalist for a long time, and a lot of what I do is trying to find a fresh, interesting new angle to something that's not really new, like, repeal and replace. We had to come up with ways of telling that story day after day after day after day after day for quite a few years. When I started doing a magazine piece for Politico about a year ago on this topic, I knew nothing about it. And I had more fun doing this piece than anything I've done in a really long time, because there's so much going on and it's so new, and there's so many, it's both top down and bottom up and government and private. It's lots of people working on this. And at the same time, not enough people working on this. So basically, I learned so much doing it, I wanted to ask everybody really quickly, jump in on something as you do this work, even though you're all coming to this table as experts. What surprised me was just the biggest surprise was that healthcare was responsible for 8.5% of emissions. That blew me away. But each of you just share something less cosmic than that. Start with Michael.
Sure. Thank you for having me today. I think one of my big takes is how quickly we've got engagement across the healthcare system. Sustainability used to be a one-person department, and energy was owned by facilities management. Now we have clinical staff, our surgical services, materials management, and our C-suite up to our top leaders and our CEO engaged in this topic.
And when I did the reporting, I found nursing students and med students, and it was very top. It was like places you wouldn't expect. And it was throughout, at least in the early adapters, there was a huge amount of energy of all sorts of people jumping in. Mike, well, let's go to Dr. Hardeep Singh. You're coming at this as an academic who's researching it, but you're also, it's got a practical application. You're in the real world working with hospitals making change. So something that you've seen that surprised or encouraged you as you've done this work.
Sure, Joanne. Again, it's a pleasure being here. I've come to this as a patient safety researcher and very new to the area over the last few years. And what's been striking is the commonalities between the two topics that really I'm passionate about: patient safety and climate change. Patient safety is about preventing harm to patients, and climate change is about preventing harm to not just patients, but also the public and the planet. And the solutions are very similar. They require system transformation, which includes data, technology, people, processes, culture change, all of that. And so I'm really, really passionate and encouraged by the similarities and what I can bring to the table.
And Michael, I should just start to explain that Michael, Michael works at Energy Star, which many of us know as he'll come back and explain a little bit more, but many of us know as like a sticker we have on our appliances. We buy something and it's energy efficient. It's actually a huge EPA program. They do way more than that. He'll talk about how it applies to hospitals in a minute, but just as you've done this energy efficiency work in the healthcare center, something that's popped out at you. Oh, I'm sorry. Did I say Michael? I meant I meant
no
to
worries.
say Mark. Apologies.
No worries. First of all, thank you for the invitation to be here from the Bipartisan Policy Center. We are very happy to be able to talk about this. And as you said, the Energy Star label on a consumer product is something that the vast majority of Americans recognize and know. It's on over 70 different product categories. You can't help but go into a store and find that little blue label that says this is an energy efficient product. What fewer people are aware of is that the Energy Star also designates the most energy efficient buildings in the country. And the Energy Star label on a building means that this building uses 35% less energy than a typical building on average and emits 35% less greenhouse gas emissions. So it is a very broad program that encompasses not only products, but commercial buildings and industrial plants, as well as our own homes.
Can I ask a quick question about that before we go on? If a hospital has an Energy Star certification, is that in terms of its like HVAC and ventilation and things like that, or does it also include, you know, how much food is thrown out, or you know, surgical the surgical devices that get tossed? Is it just define what that 35% is a lot? I'm just trying to understand what 35%.
Sure. 35% less energy. So this is a label that only looks at energy consumption, and it is a building will put in their energy consumption for a 12-month period, and they'll also describe a few of their operations, like the size of the building in terms of a hospital, how many MRIs it has, how many full-time equivalent workers it has. And then that tool will give the hospital a score on a scale from 1 to 100. 50 is considered the sort of the industry average in terms of energy efficiency. So right off the bat, that hospital will be able to tell themselves or find out for themselves, are they less efficient than average, or are they more efficient than average? And Energy Star certification on that scale starts at 75 or higher. So EPA 25 years ago defined an energy efficient building as one that operates in the top 25th percentile in terms of its peer group across the country.
Michael, going back to Atrium is one of the early adopters. I'm not sure how many hospitals you have in your system, but it's system-wide. Everybody's doing this, right? It's not just the...
That's correct. And I know as mentioned, I was in North Carolina, but we're in Georgia, Alabama, and we've recently merged with Advocate Aurora. And so we're in Illinois and Wisconsin as well. We have 22 hospitals here in the Southeast and about that same amount in the Midwest. And yes, we've been an early adopter of Energy Star going back many years.
And beyond Energy Star, you're also doing, I mean, for those in the audience who don't know, HHS does have a climate pledge, which is energy and other things. Well, it's energy more broadly defined. It's greenhouse gas from all sources. It's voluntary. There are currently about 15% of hospitals that have signed, yours being one of the early ones. We will know in a few weeks. They announce twice a year. They're going to announce twice a year the new people, the systems that have joined. So we'll find out during COP next month who else in the U.S. has joined. The focus of the BPC report is really on things that may be attainable that the government can encourage and do, focusing on really what we think of traditionally as energy. Given the current political climate, you're not going to have a lot more regulation. You're not going to have a lot more mandates. It's going to be an encouraging things, rewarding things, making people want to do what's right, but also transparency, sharing data, coming out and saying what you're doing. If you sign the climate pledge, you have to be accountable. You have that's part of the deal. You have to disclose things. It's voluntary, but people in the field say that gives it teeth because there's a little bit of shaming going on if you don't meet your goals. So we're talking really about things like ventilation, things like maybe Hardeep, you could talk about. One thing I learned is that it's really hard to turn things off in hospitals, or like you can't turn an MRI machine off, like because of that's the way they're made, the magnetic powers. Or I'm not a physician or a physicist, but there and also there's a habit or a way of running a hospital. They leave things on just in case, where you can turn some things off safely, or you can schedule a use, you could power down. Are there some sort of practical, like I visited UCLA and they have something like when I was doing this report, they have something like 50 ORs, and they were leading all of them on full power all the time. And they realized that even in an emergency, you don't have to have everything on. So what are some of the practical things that you were discovering hospitals can do that once somebody tells them about it or what become aware of it, it's not so, it's not such, it's a hill, not a mountain.
So is that for Michael and I? All right.
That's for you.
Okay, so you talked about MRIs. One thing you could do is most health systems have a huge weight for MRIs. One of the things we could do is do them at off hours. We just don't do that enough because either we fall short on staffing. So the whole point is we're going to have to sort of think about health system transformation, healthcare delivery system transformation. We have to do things differently. We've had a lot of discussion, for instance, on Energy Star, which is a great start. I think this report has really positioned for the first time, making some kind of a national measurement mechanism where people can report sort of energy related measurements. But you got to remember, 80% of emissions that come from the US healthcare systems relate to procurement and clinical care and transportation related things, supply chain, for instance. And we have to obviously think about energy, but we also have to think about the healthcare delivery system model. We need to think about the low value care that we are giving. So we as clinicians in the clinician community, there's a lot of discussion on how we can reduce low value care, maximize efficiency, make it safe, and reduce the low value wasteful care and reduce waste. So that's some of the things that and I'm going to put into chat a couple of resources that we've developed with the National Academy of Medicine and AHRQ that give specific guidance to hospitals and health systems on what are the things they can do, not just on buildings and energy, which I'm sure Michael will now talk about as well, but also about what aspects of wasteful care can they go and reduce.
Right. The Bipartisan Policy Center does in their report, those of you who haven't read it yet, they acknowledge the supply chain is a big problem, right? So much of what is used in hospitals is thrown out after a single use. It comes shipped from miles away. It comes wrapped in just gobs of plastic. It is used once, or even if it's unwrapped and not used, it ends up getting thrown out. So that is a huge issue. And we can talk about it. It's really important. It's not the points addressed in today's report, in the report released this week, but yes, it's important that we are aware that there's this as hard as the working out the ventilation and when you turn on your lights and things like that, that's actually the easier part than figuring out how do you change an entire global industry. But also that's one reason the HHS has told me not just me, they've said they've created this pledge because you're beginning to create demand. If you create a community, once the early adopter becomes the norm, there's more power to change the demand for different kinds of medical products. Michael, you said you wanted to add what are some of the things that when you started doing this work and you sort of started looking at your hospitals with a different eyes open in a different way, and you walk around and see that's on, what's different now? And also I'm curious if you've taken him up on the kind of scheduling changes too, because that's also an equity issue, having people who can come before or after work if they can't get time off work. I mean, I can take time off work when I need to go to something medical. Some people who are hourly wage workers can't. It's much more difficult. Childcare issues, all sorts of things. So in addition to the energy thing, there's an equity thing. So I just asked too many questions at once, but you can handle it.
Yeah. So yeah, I was going to really speak to some of the things that have been talked about from the energy standpoint. And I will say from the things that we can actually control, which is scopes 1 and 2, if you're familiar with those, energy is 94% of the actual emissions that a hospital emits. So for me, this is a really big target, and we've got to take a look at that and how do we reduce that. You mentioned MRI machines and radiology. We are partnering. Our radiologists are coming to us asking what they can do, and we're looking at some studies about ones that can go into some sort of standby mode. So there is a lot of work going on in that area because it is recognized that type of machinery can sit there at full power all the time, even when it's not scheduled to be used. So There is a lot going on there. With ventilation, our operating rooms, I believe you brought that up, are our highest ventilated areas in our hospital for infection prevention. But they don't need to be that way when they're not being utilized. So we've used what we call unoccupied setbacks to bring the OR ventilation rates down when they are not being used, but still maintain the positive pressure that they need for infection prevention. And we've put in things that we don't want to add to what our surgical staff has to do. So we put in things so this is all automated. They walk in and they have a surgical case. It goes to the ventilation rates they need automatically without them having to do anything. And that has been a big energy reduction for us.
Clark, what about, there's a question in the chat, and I would encourage other viewers to ask your questions. We'll try to incorporate them to the conversation. One of the questions was, how much in the energy savings in a building, how much can you retrofit, and how much is, okay, we're stuck with some of these old 100-year-old buildings. The savings, the energy savings are going to come from the new things we built. Can you sort of address that topic?
Sure. So one of the principles that we've distilled over the 25 years of this program is that an old building with older technologies managed well can often outperform a new building that is not managed well. And so we have examples of hospitals that have pneumatic controls that are very much older technology. They're not the digital systems that are currently being installed, but they are managed so well by facility operations department that they are outperforming brand new buildings. And that's great news, actually, because what this means is that any building, whether it's built 20 years ago or 5 years ago or 30 years ago, you can improve the operational performance, energy performance of that building by doing operational best practices. We have lots of hospitals. I imagine Michael has some first examples of this as well, where you go through, you do an energy audit, you look for operational changes on existing equipment. You can find 10, 15% energy savings just by managing your equipment better. Then you can get into upgrading your technologies and having further savings. You can do occupant behavior changes as well to maybe get as much as 10% additional savings on that. So the good news, the good news is poorly performing buildings today can, within a very short time period, be operating in the top 25th percentile of the country at Energy Star levels if they focus, if they do these changes. And it really is the buildings that we have now are going to be the ones that emit most of the greenhouse gas emissions because they're existing. The ones that, yes, there's new hospitals being built all the time, but the vast majority of the opportunities available come from existing buildings today.
We'll start with Michael, but then the other two of you might want to weigh in on this as well. It's another audience question, although it was on my list, which is ROI, right? Doing the right thing can have rewards of its own. I mean, you're in the business of health. You're supposed to be making people healthy, keeping people healthy. Climate change is bad for our health. But you're also running, you have to deal with investment and costs and so on and so forth. So are you saving enough money that it helps you make the case? And are the resources available through the Inflation Reduction Act? When I was reporting on this, and obviously I didn't talk to everybody hospital in the country, it took a while for anyone to even mention to me. I didn't know that those resources were there. And a lot of other people in the field didn't seem to either. And even when I talked to the chief environmental officers of some health systems, they didn't know about it. That was several months ago. It may be better, but start with you, Michael, and then I'll let the others two chime in on this. Like, is this a cost saver, or is the initial cost a barrier, even if you're going to save later? Because the hospitals have been hurt the last few years. It's tough.
Yeah, so I want to back up real quick and then I'll come to that. But new buildings versus old buildings. So I've done an evaluation, and in 2030, our new buildings will be about 12% of our overall carbon emissions. So it really is imperative that we address our existing and our older buildings. And we've been very successful reducing energy consumption in our older buildings in our older hospitals by 35%. Across about 7.5 million square feet of acute care portfolio. So they do have to be addressed. And even older technology like pneumatic controls, which Clark brought up, I didn't think this was possible, but we actually have two of our 7 hospitals that are Energy Star certified, operate in the top quartile, have more than 50% pneumatic controls. So it can be done. So the business case, all of our energy projects have been sold based on a financial payback. We've had to provide a payback of 3.5 to 5 years or less on all our energy projects with an internal rate of return on top of that. So it is, to date, all of our energy has been sold on the financial business case. As we're moving forward with, you mentioned we have signed the Health and Human Services pledge to reduce our emissions by 50% by 2030. We've also taken that a step further by having a goal of being carbon neutral 2030. So that plays in, and hopefully what that will do will expand the ROI a little bit to allow us more projects, but financial business case is part of all of the projects that we're doing.
I believe, and someone can correct me if I'm wrong, I believe that Kaiser Permanente their health system is carbon neutral now, and that they were the first major health system to achieve that. Am I right? Anyone else want to comment? Either one of you want to talk about the startup investment versus the payoff? I mean, how quickly they're doing it in 3 years, 3.5 years?
The old view was energy was a fixed cost of doing business. You got a bill, you had to pay for it. The more enlightened view is that energy is a variable cost. You can reduce it, just as Michael has explained. You can take an existing building and you can shrink that energy consumption by smart investments, by best operational practices. We know that the typical building in this country wastes 30% of its energy. And so that is money that hospital could capture and save it and then put it back into offering better healthcare services to its patients. Why wouldn't you want to do that? It's a competitive reason, it's a cost savings reason, and it's a public health reason for doing that.
Hardeep, when you work with hospitals or come across people like Michael trying to make these changes in the health sector, is there an instinct that you have to help them overcome about that this isn't safe, that we can't reduce our ventilation, we can't use something reusable because of infection, we need to keep using the disposable things? We have come to think that certain things are the way to do it when in fact there are safe alternatives. But how easy is it to reassure? I mean, physicians don't want to do things, or any clinician, nurses, physical therapists, whatever. I mean, whoever it is, they don't want to use something that they think can spread infection. They won't want to work in an OR that they think doesn't have safe enough air. The research base has grown, but there's still a perception that has to be overcome. Are you encountering that, and what do you see? How are we overcoming it?
Sure, Joanne, before I address the question on sort of safety, I want to sort of build on some of the comments Michael and Clark made around sort of this business case. Of course, I mean, I think there's a myth that this is going to be costly because people don't realize there's actually a lot of, return on investments on, especially with the energy. And of course, you should do those first because they can give you immediate return on investment and then invest some of the money on other longer term initiatives. But there's also, in fact, we're writing a paper with the National Academy of Medicine, sort of touching upon what is the case to do all these activities. So, a couple of the things I want to sort of highlight, it's not just about the finances, right? I mentioned high value care in addition, so we could reduce a lot of waste and sort of gain, economic benefit from that. The second is societal benefit. Just in 2018 alone, there were almost 400,000 disability adjusted life years lost because of pollution. Where does that factor in, right? Sort of the public health and societal damage from all of the climate change related illnesses that we're encountering. Then there's this reputation the sort of benefit. So I think if you can clearly see some of the health systems that are working on these initiatives, they're going to attract not just patients, but also clinicians. We're hearing from people, they are wanting to go and work in more and more sustainable hospitals. So if people have a choice, and this has already been shown in business literature, where people are saying, I want to go to a company that is working on sustainability and climate change related issue versus one that is not. So this is sort of one of these big factors as well. And so another one I mentioned was equity. I mean, you mentioned equity earlier. This is an important issue. Hospitals and health systems are already working on equity issues because CMS and Joint Commission have sort of had some of these sort of topics and made this a big priority. So there's a lot more than just the business case, the financial case. A lot of these other things are sort of playing into the picture as well that we need to be thinking about to sort of get people motivated to, take these initiatives on. And now your original question was about, safety. How do you balance the
perceptions of safety?
The perceptions
So
of
it's
safety.
safe, but people are understandably nervous, right? I'm used to using something that I use once and throw out. I'm afraid to use something that you told me was reprocessed. I'm afraid, we just went through a traumatic pandemic. How are you? Our buildings are not, our buildings are not well ventilated. Our schools are not well ventilated. It's easier than people think, or so Joe Allen keeps telling me. But there's a fear that we're going to make things worse. We're going to make things unsafe. That the way we do things is necessary. So,
right. So two things here. Obviously, there are genuine concerns about people think, well, what about, I want to have only disposable. But there's now emerging research to show what are the FDA sort of, suggestions and proposals around what are the things that can be reprocessed and reused. And, the evidence is quite clear on at least some of the items. And those are the ones that we're advocating. And in fact, I'm going to sort of put this sort of paper in the chat as well. You got to remember, we go to restaurants and eat with utensils that have been used by other people as well, right? So not everything is going to be sort of perfected to being germ-free. It's the high-risk devices versus the low-risk devices that we're talking about. We always have this myth that, we want like zero harm, absolutely zero. Zero harm is aspiration, but sometimes it's sort of a goal that is sort of interfering with some of the big picture changes, sort of what we need to make in this topic. There is absolutely good evidence that some of these single-use devices can be reprocessed safely. So we just need to sort of make sure that all the sort of the federal bodies as well as the trade organizations are on board with making sure that the hospitals and the clinicians feel safe and show them the evidence in this area.
Do any of the three of you know whether the Joint Commission is just starting this voluntary certification for hospitals and health systems? Is this, do they have an accompanying program to do this safety data and that safety reassurance? I know a couple of hospitals, I think there are only 9 health systems have chief medical environmental officers now, in addition to the more engineering type, and they're dealing with this clinician to clinician conversation. Yes, this is safe, but does anyone know, is there an organized effort to sort of make people understand that this is in fact not just the safe, but the safer way to go?
So, Joanne, I'm just going to start, and maybe others can build it. We just wrote a paper in Journal of American Medical Association, JAMA, about talking about these things, and we call for changes in federal policy, and we asked for CDC, FDA, and others to sort of come together to come up with the exact type of guidance. Some places there needs to be some reform of guidelines, so we're going to have to go back and look at the evidence. And at some places, FDA will sort of, work with the manufacturers to make sure that the evidence is sort of there to, and like you said, ensure that these products are used safely. So yes, this requires effort, but we are putting a lot of plastic into our bodies right now.
Yeah.
And we have to stop.
Michael, you
gotta slow this down.
Sorry, Michael, you put something, excuse me, Clark, you put something in the, well, you both put things in the chat, but Clark, this is one for you. You did say there is a site on at the EPA about green hospitals, but can you, about hospitals moving to renewables, can you sort of quantify that a little bit? Are they going totally solar, wind, et cetera? Or can you, if you can't do all of it, I mean, are there some sort of on a continuum where there may not be yet doing everything that they may be doing 5 years from now, but it is becoming common to at least begin to transition?
Yeah, I'm a little bit out of my wheelhouse in knowing sort of the renewable stats for healthcare systems, but I do want to mention to the person who asked the question that we have a sister voluntary program at EPA called the Green Power Partnership. And it is free to join, just like Energy Star is. And the program teaches organizations how to purchase green power, whether it be typically through the renewable energy credits, which would be offsite green power purchases, or I'm not exactly sure what it provides in terms of on-site, but it does have a couple healthcare systems as a partner, including Kaiser, which is how I knew that they had 100% green power through the purchase of renewable energy credits. The other thing that I wanted to mention too is that the Energy Star certification is going to be evolving next year in 2024. We are, for the last 25 plus years, that logo has meant an energy efficient building or product. Next year, that logo will evolve into what's called Energy Star Next Gen. You'll still have the ability to earn that label for just having an energy efficient facility. But for those healthcare systems that want to purchase green power and begin to partially electrify, then they will be able to earn that Energy Star Next Gen certification, just like they do the Energy Star certification today. And as more and more healthcare systems begin to earn that, then we will be able to, at EPA, have a clear picture of, in this case, how many healthcare systems are buying their power, from renewable clean sources.
One of the recommendations in the BPC report was to find ways of getting more hospitals, either a requirement or an incentive, to use and report. I might be getting the exact name of the Energy Star production. What's the monitoring? Energy monitoring.
The tool is called Energy Star Portfolio Manager. So organization.
That's like looking at the entire use of all energy in a health system.
Yeah, it is whole building specific. So when you get a score for your hospital, it is not about particular systems in that hospital. It is about the entire whole building, how each of those systems sort of interact with each other to get what that energy consumption is. We know from this program that hospitals, like the worst performing hospitals compared to the best performing hospitals, there will be like a 4 times energy difference between the worst and the best performing hospitals. Now, what are the best performing hospitals doing that the worst performing hospitals aren't? And that's the whole value of benchmarking. It enables you to see where that building is on that 100-point scale, and in a very easy way, learn how energy efficient that facility is. And then the tool allows the hospital to start setting explicit performance goals through time. So you might be at a 50 today in terms of an Energy Star score. You might decide, hey, let's shoot to be an Energy Star 60 in 2 years. What can we do now from an operational perspective, from a capital upgrade perspective, and an occupant behavior change perspective? What can we do to improve the energy performance of our facilities and reduce our greenhouse gas emissions.
And is this
And-
publicly available? Like if I'm a health system, anyone, and I'm using this product, so it becomes a public metric?
Yes, this is a tool that is available at energystar.gov/benchmark. It is free to use. These are private password protected accounts. You can go in, and we've got extensive training resources that allow you to learn how to use this system. And Michael, you've got plenty of experience in that. How's the Energy Star portfolio manager experience for you?
Go ahead.
Yeah, so Energy Star is where we started, and we didn't know what opportunities we had until we benchmarked our buildings in Energy Star and saw our score and something else that it gives you, which is energy use intensity, was the amount of energy per square foot, which is a really, really great number. We also use it to track waste and water in a number of our buildings. I believe water is going to be our next frontier, so it's a great place to do that. And in facilities management, it's like we benchmark everything we do except energy to a certain extent. Now we do, right? But we will, the number of employees we have per square foot or adjusted patient day, the number of dollars spent on contracts, just all sorts of things. So it makes sense to track our energy. We've got to find out where we are so we can find our opportunity. The Energy Star offers a number of tools also. There are energy conserving checklists that you can get from their website. There are, you can input in Portfolio Manager what you'd like to see. If you got a 10% reduction in energy in your building, what's that dollar savings? So there's a lot of tools there also, and not just the benchmarking, which is where we've got to really start. Because once we saw where we were, it really was our first call to action.
Yeah, and I was going to say, Clark, I've always sort of wondered, can patients go and look and see what the Energy Star rating is for the hospitals they use and compare the 5 or 7 that they have the choice over? And will that day, if that's not there yet, then when will that arrive?
Well,
I think that's coming. I mean, but I think maybe not patients going online to figure out how to understand an energy monitor, but marketing that they're a green hospital, that they're an earth-friendly hospital, that they have a garden, that they're composting. I mean, that's some of the hospitals I talked to also said it's a recruitment thing in an era of health, health workforce shortages, particularly the younger doctors or nurses. They want to go someplace that's working on this. That there's and not only the younger ones, but there's this internal demand too. And I think in an era where you're not going to have a lot of government regulation of this, you're just going to have to make people want to do it because of the ROI. It's good business, and it's also good for health, and it's morally right. It's not always easy to get there, but there does seem to be, and all three of you are probably encountering it, where people who, and there's still change resistors. It's not like this is solved, but the body of early adopters is growing. A question for you, also, Hardeep.
Joanne, before you get in, if I can add to Hardeep's question, can patients do this? In actually certain parts of the country, they can. We have over 45 jurisdictions across the country, primarily cities, but a few states as well, that require mandatory energy benchmarking. And that means that buildings over a certain size will have to report their energy use to their local jurisdiction as a annual sort of event. And cities are doing that because they have greenhouse gas emission reduction goals that they cannot meet unless the commercial buildings within their jurisdiction also improve their energy performance. And so it is not uncommon for the cities that do it. And I'm thinking of Philadelphia as one of these cities that does it. They have a map in their on their city website that you can scroll over buildings, and you can see the Energy Star score of all the buildings within their jurisdiction that fall under the particular mandate. So this is probably the most sophisticated and most transparent way. There are sort of different degradations of this when you look at all these different jurisdictions, but it is a very fast growing trend among cities that have greenhouse gas emission reduction goals. And I would expect more cities will be requiring hospitals and all other types of buildings to begin reporting their energy use, as well as what's also called a building performance standard, which are thresholds that of energy intensity that a building must meet, or they face the possibility of fines if they don't.
Dave, you work with,
I was just going to respond.
I have a follow-up question too.
Yeah, Clark, I was going to say absolutely. And, California just passed this law, I think it's SB 253, that, requires public sort of, reporting of greenhouse gas emissions. And so I think there may be some state requirements that would expect you to do this anyway. I think it applies to like hospitals that have more than $1 billion, maybe revenue or budget or something like that. But there are sort of requirements coming that would require some of these things to be disclosed.
Another question, are you, this is also an audience question, it's a good one. Is this something that little independent or smaller systems, less resource systems, just littler systems, or one local like community hospital, are you able to do this if you're not a big, a big system with a lot of resources, expertise, and more economic resources? Are you seeing it? I mean, it's all over it, you're not seeing, I mean, I'm not going to name names, but when I was researching it, some big name hospitals that I would have expected to be doing a lot weren't. They weren't doing much at all. The UC system is mandated by the state. I mean, can a small little onesie twosie hospital system do this in a state where it's not a priority necessarily for their local government or their state government? Can the little guy?
We have hundreds of critical access hospitals, rural hospitals that are benchmarking in Energy Star Portfolio Manager, and they are, just as Michael said, they're finding that their hospital has major opportunities to improve energy efficiency. And we have all kinds of training resources, live trainings, pre-recorded trainings on our website that people can go to, learn how it's done relatively quickly, get the account set up, and start benchmarking really quickly. It's a very easy and intuitive tool to learn how to use.
And
Dave, what are you seeing from a
Joanne, I must add, OCHI, which is the Office of Climate Change and Health Equity based out of the Health and Human Services, has been doing a lot to sort of promote the use of IRA funds for hospitals to get moving in this direction. I think, and I put a link in the chat, they've just had this huge sort of push on trying to get health systems to think about this. But the goal is every health system, no matter where you are, should do something. And what that something to get started will lead to some sort of a benefit that you'll say, oh, wow, we're actually starting to save money. So I think the goal is to sort of start, get some governance around it, get some sort of people dedicated to the cause, and get moving, no matter how small or big you are.
Michael, as HM has done more of this, can you talk about the ways that it did start bubbling up, and it was not something done by the engineering department or the facilities managers, that there are all sorts of little tiny things that add up. So how do you create a climate in which people feel encouraged to, some solutions probably don't work, but the culture becomes, this is not just those engineers in that building, that this is all of us. And so how do you change the culture? And if you can give examples of even some small things that collectively add up, that a nurse told you or a med student told you. I mean, not maybe you personally, but that some of the facility workers have come up with, like, all these smart little things that, there was one of the anecdotes I used in the story I wrote was those socks you get, the patients get the no slip socks. Everybody gets those, and that somebody created a bin for them, and they wash them and they give them to the homeless instead of throwing them out. So that's probably a lot of socks at UCLA, right? So, so the culture change and how that's becoming a climate change.
Yeah, so the culture change really did start in our facilities management group, and we had to start there as they're responsible for a lot of, especially the ventilation and the heating and the cooling issues, and so there's a big focus in getting that to happen, and it starts with just sitting down and talking about whether it's on a daily basis as part of the day kickoff or a weekly to talk about energy efficiency and to look around and see what you see could change to reduce our energy consumption, and ideas start popping up. I mean, whether it's we haven't replaced LED lights in this wing, or it's we're leaving kitchen equipment on full time all the time, and there's stuff we could cut down there, or even, we had a lighting control system in our cafeteria that had never been turned on, and so one of our staff brought that up. And so it's the continual discussion about it, and then celebrating the wins. When we have a hospital that gets Energy Star certified, we make a big deal about it. They get a luncheon, they get awareness with the hospital president. We try to reward our teammates, and celebrate these wins. And it can be other small stuff. As we've gotten our building automation system vendors involved, we've asked them to bring their knowledge and their expertise. They see more buildings than just this one hospital or that one hospital. Bring that, and so we've set up quarterly meetings with them and quarterly training systems with them and our teammates just to talk about things that they have seen that we might be able to implement.
We only have a couple of minutes, and I'm going to ask you each if there's one last thing you want to share, but maybe one of you, whoever's the right person to answer this. How much do we know about telemedicine being an energy saver? I mean, not only are the patients driving less, it's often their daughter-in-law is also driving less. You've got that extra. The daughter-in-law gets the mother-in-law, and so there's two legs each way to the hospital and back. Do we know if it's energy efficient, or we haven't measured it, or it's not as much as we might think?
Yeah, Joanne, transportation costs, definitely. There's several papers now in JAMA that talk about this as a cost saver in transportation and emissions sort of saver. And Michael, your system probably already has lots of telemedicine initiative, and so does the VA, encouraging the use.
Because there's a lot of debate about the future of who pays for it, and that's a whole nother event. But we don't want to go totally virtual medicine, but there are things that are safe to do virtually, and it would seem to be a green practice. Although I don't know how. When I looked at that a few months ago, there wasn't much data, so I can now go look for it now. Closing? I mean, I guess I'd like each of you to just quickly, because we just have a minute or two to, and I'll start with Michael about this, the momentum. And also, do you still feel like you're an early adapter? How much, are people calling? I mean, we only have a couple minutes, you have to answer quickly, but like, how much bubbling up are you seeing? How much is the moment here? Or are we still in the early adapter world?
So I think we're in the early adapter world, and I think we've got some people who are leading, and they have signed the HHS pledge. They've set carbon neutral goals, and there's a lot of discussion going on, and we're all telling our stories. And from a facilities management, I mean, this is like the perfect storm, pun intended, that, energy efficiency is getting the awareness that it really should have, because everything we can do to reduce our energy consumption reduces our natural resources, reduces our carbon emissions, and plays right into everything that's going on in this field right now.
Hardeep?
Sure. I'm very proud to be part of a federal health system, Department of Veterans Affairs. As many of you know, the reason there's a HHS pledge is because there was a very powerful executive order by the president, December 8th, 2021, 14057, that sets the federal path to net zero by 2050. All the federal health systems have been already doing some of this work for the last 2 decades. In fact, I just put in chat some of the reports and sort of the graphs. You can see we've been working on energy sort of efficiency for decades, and there's infrastructure, there's governance around. And I think now if the sort of the feds have got together to respond to the executive order, and we could be great partners with the private health systems to sort of move the needle forward. Even though I think some private health systems are a little more advanced than the others. I mean, we're learning at the same time as a federal health system. There's plenty to do and there's plenty of work ahead. Thank you.
And Clark, 3 seconds. Are we in the early adopter world, or in your corner of it, it's spread?
Well, we're in the early adopter world in terms of having a building that is going toward net zero and green power and electrification. But EPA will, as I mentioned earlier, will be launching this new certification that hospitals can set a goal to achieve. It's measurable. They can track their progress to that goal over time. I would absolutely encourage any system, any hospital system, to benchmark in Portfolio Manager and set that goal to achieve Energy Star certification. We know that very poor performing facilities initially can get there. There are many examples that we have of hospitals getting to Energy Star levels within 5 years, but you got to focus.
So I want to close out on that note. The audience I got most of the questions in. They were good questions. Thank you to the audience. If there are any journalists listening to this or watching it later, call your local hospital and ask them what they're doing. You'll get a good story out of it, whether they're doing or not doing. Either way, it's a good story. Thank you to Commonwealth. Thank you to the BPC. This is it's been a really interesting conversation. I'm going to write more about it. I hope other people join me. It's interesting and it's important. And thank you for talking about it with us.